We often just assume our feet are fine, right? But the truth is, a foot ulcer can be surprisingly tough to treat.
Especially when you don't have access to all the usual resources. It's a massive issue globally, but doesn't always get the spotlight.
Exactly. Which is why today we're doing a deep dive into this really significant paper. It's the Wound Bed Preparation 2024, DELPHI Consensus on Foot Ulcer Management in Resource-Limited Settings.
And our mission here really is to pull out the most practical, usable insights from what these experts agreed on.
Think of it as a shortcut for you. Understanding how to tackle foot ulcers effectively, whether you've got everything you need or, well, almost nothing.
Right, and this wasn't just a couple of people either. It was 41 wound specialists from 15 countries. They used a really rigorous process, the DELPHI method, to reach this consensus.
And we need to be clear about resource-limited settings. It's not just about, say, low-income countries.
No, not at all. It could be rural areas, remote communities, indigenous populations, really anywhere globally where things like supplies, equipment, specialists, or even advanced skills might be hard to come by.
Okay, so what's the plan? How are we breaking this down?
We're going to unpack the key recommendations. We'll start with figuring out the root causes.
Okay.
Then talk about patient-centered care, especially when things are challenging. Then looking at whether a wound can actually heal.
Healability, right?
Yeah. Essential local wound care stuff, how vital it is to track progress, and finally, sort of the bigger picture, how we can improve healthcare systems overall.
Great. Let's jump right in then. Identifying the root causes. The consensus says the absolute first step is checking blood flow to the foot.
Yeah.
Why is that so fundamental?
Well, think about it. Good arterial blood supply is basically the foundation for healing. Without enough oxygen and nutrients getting there, the tissue just can't repair itself.
Simple as that.
Pretty much. So the consensus really stresses checking for pulses. You can feel palpable pulses, specifically the dorsalis pedis, that's on top of the foot, and the posterior tibial behind the inner ankle bone.
Okay.
And if you happen to have an 8 megahertz Doppler, that's a little handheld ultrasound device, you can actually listen to the flow.
What is this thing for?
Ideally, a multiphasic sound. That means like biphasic or triphasic. It sounds healthy. But if you hear just a single sound, monophasic or worse, nothing at all.
Uh-oh.
Yeah, or if you just couldn't feel those pulses in the first place, that's a serious warning. It means you probably need to get a specialist involved. It could be PAD, peripheral arterial disease.
Which restricts blood flow.
Exactly. And it's super common in people with diabetes.
And the paper mentions specific tools for this, the ABPI and the AHHD.
Yes. The ABPI, the ankle brachial pressure index, is standard. It compares blood pressure in your ankle to your arm using that Doppler.
Right.
But interestingly, they put quite a bit of emphasis on the AHD, the audible handheld Doppler.
Why is that one so useful?
It can be really valuable, especially, again, with diabetes. People with diabetes often get arterial calcification, basically hardening of the arteries.
And that messes up the ADPI reading.
It can, yeah. Makes it unreliable sometimes. But the AHHD assessment isn't really affected by that hardening. And here's a really neat point.
Go on.
You can actually record the Doppler sounds, like an MP3 or MP4 file.
Seriously?
Yeah. And you can send that recording off remotely for an expert to listen to and interpret. So even without a vascular specialist right there, you can still get their opinion.
Wow, that's a brilliant way to use simple tech to bridge gaps in access. What about other circulation issues, like veins?
Yeah, definitely. Chronic venous insufficiency, where the leg veins struggle to send blood back up to the part that can cause foot problems too, sometimes alongside the artery issues.
What are the signs for that?
You might see varicose veins, leg swelling, maybe some skin discoloration, and typically venous ulcers, often down low on the leg, maybe on the inside ankle area.
And the treatment?
For venous ulcers, the big thing the consensus highlights is compression therapy, using special bandages or stockings to improve that upward flow. Plus, elevating the legs and encouraging walking helps too.
So it's not just arteries. We need a wider view. The consensus talks about an AIM mnemonic for finding all the causes. Can you explain that?
Sure. AIM stands for Assess, Identify, Manage. It's a good framework, especially with diabetes, starting strong with looking for neuropathy, that nerve damage causing loss of feeling.
Right.
But In places with fewer resources, you often see other things piling on, like people showing up for care really late.
Delays in diagnosis.
Exactly. Or walking barefoot, wearing bad shoes, maybe hygiene issues, or just not knowing how important foot care is.
Are there specific examples?
Yeah, like studies from Ethiopia pointed to things like humidity, existing foot deformities, even fungal infections playing a part. And research on leprosy patients with foot ulcers found links to not feeling that light touch test, meiji foot shape changes, lower education, unemployment, things like that.
So AM forces you to look beyond just the wound itself.
Precisely. Look at the whole picture.
It sounds like a really thorough checkup is needed then. What specifically should be part of a routine foot exam?
Okay, so regular exams need to hit several key areas. First, neuropathy checking for that loss of protective sensation, usually with that simple 10-gram monofilament test, just lightly touching spots on the foot.
Okay, neuropathy check. What else?
Vascular status, feeling for those pulses, maybe using the Doppler, like we said. Then spotting signs of infection. That's critical.
How do you spot infection?
The consensus points to the NERDs criteria for superficial signs. That's non-healing, exudate, red and fragile tissue, debris, and smell.
Nerdies.
And then stones for possibly deeper trouble. Size increasing, temperature up like 3 degrees Fahrenheit, warmer than the other foot.
Okay.
O's, meaning you can probe down to the bone. New breakdown areas, erythema, that's redness spreading more than 2 centimeters, more exudate, and again, smell.
Nerds and stonies.
Yeah.
Useful acronyms. Anything else in the exam?
Yes, finding high-pressure spots. These often show up as calluses. And they even mention a simplified 60-second screening tool, something quick for healthcare workers to do an initial risk check.
Very practical. Now, what about emergencies? Like if someone with neuropathy comes in with a foot that's suddenly hot and swollen.
That is a major red flag, especially since they might not feel pain normally. A hot, swollen foot with no obvious injury could be acute Charcot neuroarthropathy.
Oh, that sounds serious.
It is. It involves bone and joint damage. And this is where something really simple like an infrared thermometer can be a lifesaver.
Wow.
An acute Charcot foot can be way warmer, maybe 8 to 15 degrees Fahrenheit hotter than the other foot. These patients need immediate medical help. Often involves immobilizing the foot in a special cast, a total contact cast, to take the pressure off and stop more damage. So yeah, warmth can be a huge clue.
And you mentioned calluses earlier. How exactly do they lead to ulcers?
Calluses build up because of too much pressure and sheer force on the skin, especially if you have neuropathy and can't feel it happening.
From foot deformities, bad shoes.
Yeah, all of that.
Yeah.
Limited joint movement, just the repetitive stress of walking. The danger is you can get bleeding under that thick callus. Eventually it breaks down, opens up, and boom, you've got an ulcer.
So dealing with calluses and pressure is key for prevention.
Absolutely. Regular checks, proper footwear, maybe custom insoles to offload these pressure spots. It's vital.
The consensus also differentiates types of diabetic foot ulcers.
Yes, and knowing the main cause helps guide treatment. You've got neuropathic ulcers, mostly from nerve damage and loss of feeling.
Okay.
Ischemic ulcers, mainly from poor blood supply, that PAD we talked about.
Right.
And neurochemic ulcers, which are, well, a nasty mix of both nerve damage and poor circulation. Knowing which type you're facing helps you tailor the plan.
With all these factors, how do you prioritize treatment when resources are tight?
Good question. The core idea is triage. Address the most critical problems first, using whatever resources you actually have.
And diabetic foot ulcers are high priority.
Extremely. They're common and carry huge risks like amputation. Things like chronic high blood sugar, PAD, even just dry skin are big risk factors. And interestingly, big swings in blood sugar can also cause long-term harm.
Wow.
And remember, up to half of people with diabetes get neuropathy. There's no cure for that, so it's all about inspection, care, and glucose control.
And PA often goes unnoticed.
Very often underdiagnosed, despite being common. The consensus also pushes for good blood pressure management in diabetes and highlights certain drugs, SGLT2 inhibitors.
Ah, yes, those.
They do more than just lower sugar. They protect the kidneys and heart, too. So immediate priorities often are stabilize the patient, fight any infection, and improve blood flow if possible.
It really sounds like a team effort is needed.
Definitely. The consensus hammers this home. An interprofessional team approach is necessary. You have to consider the biology, yes, but also social factors, geography, culture, everything influences the outcome.
They compared Denmark and Canada.
Yeah, they contrasted Denmark's integrated care model, which lowered amputation rates, with disparities seen in places like Ontario, Canada, especially affecting Indigenous peoples, immigrants, and rural folks. But they also highlighted positive examples like the Indigenous Diabetes Health Circle, showing culturally sensitive approaches work.
And finally, on causes pressure redistribution. How important is that?
It's absolutely foundational for foot wounds. The gold standards are things like total contact casts or special removable walkers patients can't easily take off.
Well, people don't always use them.
Adherence can be surprisingly low even when they're available. So, in resource-limited settings where you might not have those fancy boots or casts, the consensus says get creative.
Use local materials.
Exactly. Use what you've got to make offloading solutions. The key things are safety, monitoring closely, involving the patient every step of the way, and having a feedback loop to improve your local methods.
So ingenuity matters.
Absolutely. Understanding the principle of pressure reduction and applying it smartly can be really effective, even without high-tech gear.
Okay, let's shift gears to patient-centered concerns. Pain is obviously a big one. How should that be handled?
First step is assessing it properly, using a simple pain scale, like 0 to 10, where 10 is the worst pain imaginable.
Standard practice.
Right. Then you develop a specific plan for that patient's pain. You need to think about both nociceptive pain, that's from the actual tissue damage, and neuropathic pain.
Which feels different.
Yeah, often described as burning, tingling, shooting pain, nerve damage pain. And the consensus really points out that wound pain is often downplayed, but it hugely impacts quality of life.
And it can signal infection.
It can be an early warning sign, yes.
Yeah.
So underestimating pain is a mistake.
So what goes into a good pain assessment?
You need a thorough history. What kind of pain is it? Sharp, dull, burning? When did it start? How long does it last? What makes it better or worse?
And keep checking.
Regular reassessment is vital. See if the plan is working, make changes. They even suggest maybe using pain diaries for patients to track things themselves.
Makes sense.
And remember, pain management isn't separate. It's part of that whole wound bed prep framework, treating the cause, the local wound, and the patient's concerns like pain.
So what strategies does the consensus mention for managing the pain?
It covers a whole range, pharmaceutical and non-pharmaceutical. For regular tissue pain, nociceptive pain, things like acetaminophen, maybe NSAIDs, but with caution.
Why caution with NSAIDs?
They can have side effects, especially in older adults or people with kidney problems. For severe pain, opioids are mentioned, but obviously with careful consideration given the concerns around chronic use.
And for that nerve pain?
Medications like gabapentinoids, certain antidepressants like tricyclics or SSRIs, even cannabis where it's legal and appropriate. Topical things too, like EMLA cream or topical diclofenac for localized relief.
But what about non-drug approaches, especially where meds are scarce?
Exactly. This is key for resource-limited settings. The consensus puts huge emphasis here, things like really gentle wound care techniques.
Necrotic care.
Yes. Encouraging appropriate activity, good nutrition, maybe external things like massage or warm compresses, relaxation techniques, physical therapy, even cognitive approaches.
Extracts.
Mentioned as well, alongside actively involving the patient. The thinking is these non-drug methods might be more practical, affordable, and culturally fitting in many places. Meds might be reserved for pain that isn't controlled otherwise, especially that tricky neuropathic pain.
Beyond physical pain, what other patient aspects are crucial?
Understanding the impact on their daily life activities of daily living, ADLs, can they walk, dress themselves, manage hygiene?
Yeah.
Also looking at harmful habits, smoking, drinking too much, substance use, because those definitely hinder healing, and crucially, patient education.
How so?
It needs to be sustainable, tailored, involve their family or support system, be in their language, and really respect their culture, religion, beliefs, social norms, everything.
That cultural piece seems especially vital in these settings.
Absolutely critical. The consensus talks specifically about indigenous populations globally. Things like historical trauma, socioeconomic issues, lack of culturally safe care, maybe reliance on traditional healers, isolation, even bias in the system. They all create huge disparities.
And cost is a factor.
Big time. The financial strain might push people towards traditional healers. Plus, if the ulcer makes it hard to move, just getting to follow-up appointments is a challenge. Social support, family environment, they become incredibly important.
And managing the wound at home must be stressful.
Immensely. Dealing with odor, pain, changing routines. It hits social life, self-confidence, mental health. Anxiety, depression, feeling less capable, it's all linked.
So asking people to make big lifestyle changes in these situations must be tough.
Very tough. The consensus says you need clear reasons for any changes, and you have to consider the real-world barriers: financial, social, logistical.
It's about a partnership.
Exactly. A biopsychosocial approach. Look at everything: biology, psychology, social situation. Create plans together that actually work within the patient's reality.
Okay, let's talk healability. The consensus gives 3 categories.
Yes. Healable, maintenance, and non-healable.
Define those for us.
Okay. Healable means there's enough blood supply and the underlying cause can be treated. Maintenance means blood supply is okay, but other factors, maybe the patient can't fully follow the plan, or the healthcare system lacks resources, prevent full healing.
And non-healable.
That's when the blood supply is just too poor and can't be fixed, or there's some underlying condition you can't treat effectively enough for healing to happen.
So that initial assessment we discussed is key to deciding which category fits.
Absolutely. The history and physical exam tell you the cause. They also mention hard-to-heal wounds, ones that get stuck. They might start as maintenance, but could become healable if you dig deeper and find something treatable.
And you need to manage expectations.
Hugely important. Be realistic with the patient about what's possible given the resources and skills available.
And the management approach changes based on the category.
Totally. Non-healable. Focuses on protecting tissue, preventing infection, often means keeping the wound drier.
Maintenance.
Also about preventing more loss, often managed quite dry too.
And stalled, but healable.
That needs urgent reassessment. Get the team involved, find the barrier, fix it.
Right, let's get into the details of local wound care. Examining, measuring, monitoring. Why are these basics so vital?
Oh, good documentation is the bedrock of quality care. It lets you track progress, guides treatment changes, ensures everyone on the team is on the same page.
Legal reasons too?
Legal compliance, yeah. Reimbursement in some systems, data for research, quality improvement. And ultimately, it helps make care patient-centered because you're tracking their specific wound.
How do you effectively monitor progress?
Regular, consistent documentation of everything about the wound. Photos are great if feasible with consent and good technique, obviously, but consistent measurement is key. Track the size changes.
So you can see if it's getting better or worse.
Exactly. Build that objective healing trajectory we talked about. It's a visual record.
And communication between team members.
Documentation is the common language. Accurate, up-to-date info means everyone works together effectively. Using standard terms, like from the International Classification of Diseases, helps keep communication clear.
What about technology here? Electronic records.
They're becoming more common, yeah. Software, apps, they can streamline things, make sure you capture all the key features.
How's the downsides?
Potential risks? Sure. Copy-paste errors leading to wrong info, data security, privacy concerns. The consensus basically says if you don't have fancy tech, good old-fashioned written notes are still perfectly fine and effective.
The principle remains the same.
Exactly. Assess regularly, document thoroughly, keep the data confidential. Doesn't matter if it's on paper or a screen.
Okay, now debridement. Removing dead tissue in biofilm. What's the point?
It's about preparing the wound bed. In healable wounds, getting rid of that necrotic tissue and biofilm sludge creates a healthier space for new tissue to grow.
And in maintenance wounds.
There, it's more about controlling odor and lowering infection risk, since full healing isn't the main goal. But, and this is crucial,
Yes.
you absolutely must know the vascular status before you debride, especially below the knee. Some debridement can cause serious harm if blood flow is poor.
So the approach depends heavily on healability.
Very much so. Healable wound, good blood flow, cause treated. Surgical debridement, removing non-viable tissue down to healthy bleeding tissue, is first choice if you have the skills and setting.
If not.
Conservative sharp debridement might be an option, carefully removing dead tissue with instruments, but not necessarily aiming for bleeding.
And for maintenance or non-healable wounds.
Conservative sharp is only considered for removing loose, slow, or debris, very gently, without causing bleeding or trauma.
What about non-sharp methods?
For healable wounds, there are alternatives. Autolytic, using dressings to let the body's own enzymes work. Mechanical, like wet-to-dry dressings, though they're less favored now for chronic wounds. Enzymatic, using topical enzyme agents. And biological. Maggot therapy, yes. Clinical grade might be rare in resource-limited places. But interestingly, sometimes accidental incestation by certain types, like Lucilia species, can actually help clean the wound because they eat dead tissue.
But not houseflies.
No, definitely not. Musca domestica can damage healthy tissue. Before any debridement, you need to assess safety, the environment, any barriers. And remember,
Yeah.
debridement generally isn't for stable maintenance or non-healable wounds you're trying to keep dry. Only if they become unstable, showing infection signs, then maybe gentle removal of debris.
Patient goals are different there.
Right. Often focused on comfort, odor control, less pain, better ability to do daily activities.
Let's talk infection and inflammation. We mentioned NERDs and stonies.
Yeah.
How do they guide treatment?
They help you assess, but the key is diagnosing infection based on clinical signs, what you see, what the patient feels, not just a superficial swab.
Swabs have a role, though.
Yes, if you suspect infection clinically, then a swab helps identify the bacteria and what antibiotics might work. If you suspect a deep infection, you really need to try and find out the specific bacteria and their sensitivities.
How do you get a good culture sample?
First, clean the wound bed well, potable water, saline. Then sample from the base where it looks unhealthy, avoiding loose stuff or hard Escher. A tissue sample, like a biopsy or curettage, is best.
Or the living swab technique?
That's an alternative. Press the swab firmly enough to get fluid from the tissue, then rotate it to collect the sample.
And bone infection, osteomyelitis. That's tough to diagnose.
Very tough. Bone biopsy is the gold standard, but often impossible in limited settings. So clinical suspicion, like an ulcer probing right down to bone, other infection signs often has to guide treatment.
If deep infection is confirmed, what local treatments help alongside systemic antibiotics?
Antimicrobial dressings can definitely support systemic treatment. Things with silver, PHMB, iodine, methylene blue crystal violet, medical honey. Silver and honey also have some anti-inflammatory effects, which is a bonus.
Any other local options?
Sometimes broad-spectrum antiseptics might be used short-term for quick bacterial knockdown, like povidone iodine on gauze for exposed bone. But you need to watch thyroid function if used long-term. Newer, less harsh antiseptics are also available.
And antibiotic choice?
Depends. New wound, healthy patient. Often target gram-positives first. But diabetic foot ulcers often have multiple bacteria, or if the wound's old, you usually need broader coverage. Cytotoxic agents? Maybe for non-healable wounds if the germ killing outweighs tissue harm, but generally antiseptics are preferred over topical antibiotics to avoid resistance.
What about just cleansing the wound? What solutions are best?
Gentle cleansing is key. Use low-toxicity stuff, pre-boiled potable water, saline, and non-cytotoxic antiseptics. There's no single best solution for all wounds, but the main thing is, don't use stuff that harms healthy tissue.
Specific examples?
Maybe dilute acetic acid or hypochlorous acid for bugs like Pseudomonas. Antiseptics that are a bit cytotoxic, like low-strength chlorhexidine, PHMB, or povidone iodine, might be used carefully after weighing risks and benefits, especially for high bacterial load, odor, or lots of exudate.
And in limited settings?
Basic hygiene is paramount. Proper prep, storage, distribution of solutions. They also mention interest in surfactants for breaking down gutto and wound irrigation.
Controversial.
A bit. Expert view is avoid high pressure if you can't see the wound base clearly. If you do irrigate, use enough volume, maybe 50, 100 millimils per centimeter of wound length, to flush properly without causing damage.
Okay, shifting to moisture balance. How crucial is that?
Crucial, but it depends on the wound type and healability. You need to balance moisture, control infection, and make sure the patient understands the dressing.
Goals differ by wound type.
Definitely. Healable wounds. Aim for optimal moisture balance. Use hydrogels, films, hydrocolloids, alginates, foams. If it's very wet, use superabsorbents.
Mommy-olded.
Reduce moisture and bacteria. Absorbent dressings, odor control.
Maintenance.
Also, reduce moisture and bacteria, often with dressings that don't add moisture, keeping it drier. Basically, match dressing absorbency to exudate level.
Any other dressing features?
Some moisture-balanced dressings also have antibacterial or anti-inflammatory properties. For maintenance non-healable, focus on comfort, avoid making the surrounding skin soggy, and reassess regularly.
Now, this concept of a healing trajectory, what is it and why use it?
It's basically a way to track wound closure over time using consistent measurements, usually surface area.
Why is that useful?
It tells you if healing is on track, helps spot stalled wounds, or warns you if things are getting worse.
Are there expected timelines?
Sort of guidelines. Acute healable wounds may be closed in 30 days. Chronic healable. Look for 20–40% size reduction by 4 weeks, aiming for closure by 12 weeks.
And non-healable or maintenance?
No set timeline for closure on non-healable. Maintenance aren't expected to heal or worsen without some change if a wound isn't following the expected path.
Reevaluate.
Yes, reevaluate hard-to-heal wounds. Think about other diagnoses, maybe a biopsy, get a specialist opinion. You can usually get a sense of the trajectory in the first 4-8 weeks to predict closure by week 12, barring complications. But classifications can change if the wound, patient, or environment changes.
Finally, let's touch on promoting edge advancement. What about adjunctive therapies?
The idea is to consider active treatments, maybe even locally made ones, based on what mechanism you need to boost healing.
How do you decide?
It has to be a team decision. Weigh the risks versus benefits for that patient. Choose based on healability. Start early for major trauma to prevent chronicity. And always get informed consent.
Cost matters too.
Absolutely. Risk-benefit, cost-effectiveness for the system. What's the impact on the patient discomfort, cost, adherence versus potential gains like better oxygen, contraction, less swelling, reactivating cells. But even with limits, teams can find creative solutions.
What specific therapies get mentioned?
Surgery is often available for debridement, closure, grafts, even amputation if needed. Grafts can speed things up sometimes, but usually not for ischemic wounds or most venous ulcers.
What else?
Electrical stimulation has good evidence. Various devices exist, some affordable. It seems to boost cell growth, blood flow, maybe reduce bacteria.
Negative pressure therapy.
Wall-mounted NPWT for inpatients with very wet, large wounds. Start pressure low. Challenges are immobility, dressing changes, but newer disposable or even DIY options are emerging for community use.
And oxygen.
Yeah, this was interesting. Breathing high flow, concentrated oxygen, even oxygen concentrators make this feasible outpatient. Normogaric oxygen boosts plasma oxygen significantly.
When might you use it?
They suggest maybe intermittent 100% oxygen for a few days for conditions usually treated with hyperbaric oxygen, like reperfusion injuries, certain infections, large defects post-debridement. Topical oxygen is different, less understood, and they caution against uncontrolled topical oxygen or ozone due to toxicity risks.
Okay, let's wrap up with the big picture. Healthcare system change. What are the key takeaways there?
The main goal is enabling care that's evidence-based, culturally safe, and fair for everyone with foot ulcers. Improve provider skills in wound care, set up clear, fast communication between patients and the whole team, recognize that prevention is the most cost-effective approach, especially since many diabetic foot ulcers are preventable.
So screening and education.
Yes. Validated screening tools, educated teams, prevention guidelines are crucial, particularly in resource-limited areas where most diabetes deaths occur. Patient navigation is another key idea.
What's that involve?
Having a support circle family, providers guide the patient through the system. It ensures timely care, better pain management, faster access to specialists, quicker healing, boosts morale, cuts hospital visits, improves quality of life, helps adherence. It saves money in the end.
And policies.
Need organizational policies outlining best practices, pathways, adapted locally but based on guidelines, approved as standards, plus data collection for improvement. Adapt delivery models, but keep core concepts, especially communication. Digital tech can help here faster assessments, better access, smarter resource use, and document adapted practices as the standard.
So wrapping up this deep dive, the message seems to be that effective foot ulcer care is possible, even with limited resources, but it takes a systematic approach.
Precisely. Careful assessment, truly patient-centered care, using the right local techniques based on evidence, watching progress closely, and being innovative with available resources.
And system improvement.
And constantly working to improve the healthcare systems themselves. This consensus gives a really solid science-backed framework that can be used almost anywhere.
It's been incredibly insightful. It really prompts you, the listener, to think, how could these ideas spark creative solutions right where you are? How can we improve things for people dealing with or at risk of foot ulcers in our own communities? Even small, informed changes can make a huge difference.
Absolutely. And if you want to explore more, maybe look up those NERDS and Stoney's criteria, find details on the 60-second foot screen, or search for examples of successful patient navigation programs in settings similar to yours. There's a lot more out there.
Thank you so much for joining us on this deep dive into such a critical and often overlooked aspect of health.